Munich. Hi, Peter. This is Amy. We have Axel, Carlos, and Gerline here. Can you hear us okay?
Yeah, okay. So, yeah, well, we have a next case here. We are about to dilate the stent, so we just wanted to inform you about the case. Can we see the PowerPoint slide, the one?
Yes, this is our second case. This is about redilation of a stented coarctation.
Next slide.
And this is a 9-year-old, very nice girl. She had been treated 2 times surgically and 3 times interventionally. And at the last intervention, a formula stent was being implanted. And you see the weight there. At that time, she had 12 kilograms, and now she almost doubled.
Okay, so let's have a look at the pressure. You see there is a gradient about 20 to 25 millimeters of mercury and in the pullback. And when we have a lateral view now on the B plane, the angiography, can we switch to B, please? Fabio, please switch to B. Okay, so you can see it, yeah, okay. Then you see the intimal proliferation, you see the steep angle of the subclavian artery, and what you can see already is that there is a certain aneurysm at the end of the stent from previous dilatations. And if we switch now to A, then we can see the intimal proliferation quite well and the aneurysm at the end of the stent. So our plan is not to do a covered stent at this time, because we have seen that this aneurysm is stable for years now. It was done with the first balloon dilation years ago, and we want to try to keep the subclavian artery open and only try to get more lumen into this formula stent which is there in that region. So if you have 1 minute more, we can dilate it now.
Yes. Can you just talk to us a little bit about the formula stent, and is this the stent that you usually use in toddlers when you need to stent the arch, and how much do you think you can dilate it? It was 8 millimeters to start.
Yeah, well, we think this is now 8 millimeter. We will go up to 10. We could easily go to 12, and later on, hopefully, we can crack it and put a larger stent inside. But up to now, we think with 10 millimeters must be okay. Let's go ahead.
Okay.
Go down with the balloon a little bit. Okay, here we start. Give a little bit more push to the balloon. I go out because we have to give a little bit more push. That's better. That's better. Okay. Now. Yeah. So we go to 8 atmospheres. And there is a slight indentation. We deflate it and come back. Nominal pressure. Okay. Okay, we do it again with 12. I think there was an indentation left. Have you stored the image? Den nehmen Sie einfach auf, ja? Genau, nimm richtig auf. Okay, here we go. This is 10, this is 12 atmospheres. There's still a little bit indentation, but the balloon gives way, and now we go out. This is a 2 centimeter, 10 millimeter in diameter power flex, and we have inserted it through a 6 French slender sheath of Terumo, so with an outer diameter of 5 French. And hopefully we will have a good result. We will see it in a minute. We take out the balloon and do an angiography. So if you have the time, stay with us. Otherwise, we can show it to you afterwards. We take a 4 French pigtail now in order to have simultaneous pressurement across the stent with the sheath and the catheter. The wire is an Amplatz ultra stiff. So here comes the pigtail. Okay, here we go. And flushing blue, please. And flushing yellow. And then we have simultaneous blue and yellow on the screen. We can show it to the camera, perhaps. So there's still a gradient. We can flush it again. the gradient of 10. Okay. So we have an angiography to see what's the reason for and perhaps make a pullback. So if you go on with your program, you can come back to us later when we have the angiography and perhaps an analysis where the residual gradient is. Is this fine with you, or
That
want
would
to
be
stay with
great.
us?
We have one more talk, so we can go ahead and do that. We
Yeah,
will see
okay.
you in about
Maybe
15
then-
minutes.
Yeah, that's great. Okay.
Munich right now, so we can't take any questions, unfortunately. Thanks again. So let's go back to Peter in Munich. Can you hear us, Peter?
Yeah, hey, Amy. Here we are again. You see the angiography of this dilation, and what you can see is we are not quite happy with this at the moment. Well, let's say it's not optimal, but I think we will keep it as it is. We see the dilated stent. We have the impression that some struts are already broken, and if you have a closer look at the proximal edge of the stent, at the inner curvature, then you see there's obviously a small dissection as well. The dissection in the caudal portion at the other end of the stent is completely stable. There were no alterations, and the subclavian artery still is open. If we go to the pressure now, you see that we have a residual gradient of 10 and a little bit, and we can show you the pressure with a multi-purpose. Now you see on the left panel the multi-purpose, the tip of the multi-purpose, hopefully, and on the right panel the corresponding pressures. The yellow curve is the femoral artery with an inner lumen of 6 French, and the multi-purpose is 4 French. So the gradient is evidently across the stent, but at this point with the 20-kilogram baby, 20-kilogram child, we are quite happy with the result as it is, and we plan to monitor these dissections. We don't think that there is an urgent need now to put in a covered stent, which we could implant. We would like to have the subclavian artery open. The other aneurysm is stable, and the plan would be to come back, if everything is stable, with 30 kilo or so, and then put in a covered stent with the option to recanalize the subclavian artery from the arm. Perhaps you could do it at this stage as well, but with this fresh dilation and this dissection, I think we just want to see that it consolidates, and we will take a CT scan in the near future to monitor the dissections and the pressures. The child has no arterial hypertension, so I think there is no need to make things more complicated at the moment, even if it's not an optimal residual gradient-free result. What do you think?
Well, I think this is a reasonable plan. Peter, this is Carlos Pedra, and I just want to ask you and the audience, in order to avoid this situation, because you don't know if you're going to be able to break this stent in the future. I'm not that familiar with the formula stent, but in order to try to avoid this very situation, we've been implanting stents in infants, small infants, through the carotid artery. And this enables us to put a stent that we can post-dilate to adult sites, such as the 1910. So I would like to hear your opinion on that, but I totally agree with your plan right now with this patient on the table.
Yeah, thank you for this question. Well, we have quite a lot of bench testing with the formula stent, and the formula stent is very predictable that we really can crack the struts above 12 millimeter in diameter with not too much pressure. The only thing we have learned is that if you do it at once, then it's better to have the second larger stent first implanted into the formula, so that the formula did not have this foreshortening and then have this ring formation, which you will not be able to crush then. But if you first put in the second largest stent and then dilate with high pressure, it is rather predictable that the formula stent gives way.
Very good.
Peter, for one, Axel here from Berlin. Do you have any idea why in this child we have so much intima proliferation, and how will you deal with that in the future?
Well, I think, yes, there is a certain intima proliferation, and Axel, it's you, Axel Moisig?
Yeah.
I think the smaller the stent, the more intimal proliferation you have. And this landing zone of the stent was operated and pre-dilated, and all these factors probably might play a role that intimal proliferation occurs more than if you have just a native coarctation. This is just a theory, it's not proven. But we know the smaller the child, the smaller the diameter of the tubes, the more the intimal proliferation occurs, and of course has more effect due to the small diameter.
And any change meant for the treatment intervention in the future because of that?
In which direction you mean?
Yeah, maybe we will take more soon at covered stent, for example, or what could be your plan?
Well, of course, but with the covered stents, the child had only a few kilograms when we put in the stent, 12 kilograms.
Talking about
and
the future.
The subclavian artery should remain open, so there are not so many options. And with the covered stents, I don't know whether we are able to overdilate them. And short covered stents are mostly relatively bulky, and you need perhaps 9 French or so for introduction. And yeah.
I agree totally.
Peter, there's another question from the audience. Go ahead, please.
Yes, I have a question about the left subclavian artery. Why you're not dealing with it, because it looks so small today?
I didn't get it. What is the subclavian? Whether we didn't?
The left subclavian artery caliber is very small. Why didn't you deal with it, or why you didn't have a plan to deal with it today, please?
Right. When we implanted the stent, we dilated through the struts the subclavian artery. But when you have a look at the first angiography on the A, perhaps, then you see that there is obviously a double supply from the vertebral artery and from the direct way from the descending aorta. So the subclavian artery is really large, and it's only the connection which is a little bit tiny. I think at the moment where we disrupted the intima, we just would like to avoid it, because I think at this point it's only cosmetic. You can make it a little bit larger, but as you see, the subclavian artery fills and refills.
Can you show us A, please?
The A or B. Let's take B. It's intermittently filled with contrast, and this comes because it is from both sides perfused. And therefore, I think it will remain open. It's tiny. We will not get a better result because the angle to the stent is relatively steep. Even if we dilate it larger, I do not expect that there is more flow from the descending aorta. I think the proportion of the flow, whether it comes from the head or from the aorta, will relatively be unchanged. And therefore, we decided not to manipulate more at this time.
Well, there's another question in the audience.
Peter, Gregor from Utrecht. Congratulations,
Hello,
nice result. 2 questions, very short. What was the initial diameter of your Cook formula stent? Was it a 6 or 7? What was it?
8.
It was an 8, but we didn't dilate it completely. So it has a certain flaring. So 8 was in the outer portion and in the inlet, but it had a small dog bone shape already.
So theoretically, it should go up to 16 millimeters before bursting. Second question, what was your bailout strategy if you would have a severe aneurysm?
We have the Bailey aortic in 12 millimeters, and I think, how long is it? 19 millimeters long. Yes. So we have it here on the table. So if really something happened, we have already the 9 French sheath and the Bentley aortic graft here in the lab.
Peter, another technical question. I would like to learn more with you because I don't have that much experience with the formula stent. There will be a point that you're going to bring this child back to break the stent, right? So would you do that with the ultra high pressure balloon before putting another stent in, or you just put a stent and use the balloon? You know what? Because intuitively, I think that if you put a cover stent prior to breaking the stent, it's going to be harder to break the formula. So probably you have to do that first. Is that your policy?
Well, I share the same intuition, but we know from our from our bench tests that this is wrong. Even with the second stent inside, or let's say the other way around, with the second stent inside, the fracture of the outer stent is easier because you have no foreshortening at all, and the struts are broken step by step, level by level. When you first try to break it, it can happen that by the foreshortening, this is a little bit more difficult. You need more pressure, and more pressure means more risk for dissection or any other kind. So we definitely would go first for a stent, perhaps in this case a covered stent to cover the edges with this dissection, and then give full power with the ultra-high pressure balloon.
Very good, important information. Thanks, Peter.
Excellent, thank you.